Good afternoon, good morning, good evening to everyone. Welcome to the SIOP Childhood Cancer Early Diagnosis and Appropriate Referral CEDAR webinar on Burkitt lymphoma. My name is Claudia Sampor. I am a pediatric oncologist from Argentina. My special interest is retinoblastoma, clinical research, and trials. I am an active member of the SIOP Education and Training Committee. I have two co-moderators today, Mr. Neil Ranasinghe. He's a parent of the survivor of childhood ALL. He's involving in advocating for children with cancer and their families in the UK and low resource settings. He's leading the SIOP Global Health Network Education and Training Working Group, and he's an active member of the SIOP Education and Training Committee. The second co-moderator is Professor Angus O'Markey. He's a lymphoma survivor and a pediatric hematologist at the National Children's Cancer Service in Dublin, Ireland, since 1997. He did his practice pediatric and pediatric oncology training at Mayo Clinic and UCSF in the USA. He has a special interest in childhood ALL and myeloid leukemia in Down syndrome. The SIOP CEDAR project is a collaboration between SIOP and IPA, and the aim is to improve the knowledge and understanding of general healthcare providers about the initial care of pediatric patients suspected of having cancer. Today, we will hear practical advice from oncology experts from around the world on how to identify children with the suspicion of Burkitt lymphoma at the earliest possible stage. We will have simultaneous Spanish translation, so you can choose your language of preference after clicking the globe in the right bottom side of your screen. February is a special month for us. The World Cancer Day will be celebrated in February 4th, next week, and the International Childhood Cancer Day will be celebrated in February 15th. We have three speakers, great speakers today. The first one is the Dr. Mangai Suseela from India. She will present the case scenario. Follow that, a lecture by Dr. Chantal Bouda from Burkina Faso. She's going to present about when to suspect Burkitt lymphoma. And finally, Dr. Asim Belgaumi from Pakistan will present a lecture about approach for diagnosis, initial management, and referral. We will have a panel discussion with great experts, Dr. Andishe Attarbaschi from Austria, Dr. Monika Metzger from USA, and Dr. Murti Andriastuti from Indonesia. We have some housekeeping instructions. Unfortunately, there will not be there is no voice option for audience, but you can post your questions at any point of the webinar in the Q&A box. Those questions will be answered by the experts during the session, either in writing or in a live way. All the participants can receive a CMA certification through SIOP after completing the evaluation. Well, let's start. I wish you all a very interesting webinar, and it's a pleasure for me to present Dr. Mangai Suseela. After completing her medical graduation and master's degree in general medicine from Tamil Nadu, South India, Dr. Suseela is currently pursuing residency in medical oncology at Cancer Institute, Adyar, Tamil Nadu in India. She is representing SIOP Global Health Network Young in Low and Middle Income Countries Working Group. Welcome, Dr. Suseela.
Thank you. Good evening. I'm Dr. Mangai Suseela from Cancer Institute, Chennai. Today I'm presenting a case of Burkitt's lymphoma. This is a 14-year-old boy who in June 2022 had developed symptoms of abdomen pain and abdomen distension. and he went to a hospital nearby, and they had done an imaging which showed a bowel wall thickening in the ileocecal region. So he was seen by a surgeon and he underwent a right hemicolectomy. So this happened in August 2022. After the surgery, patient's abdomen distension and abdomen pain relieved. So he became asymptomatic. So he did not report back to the hospital, and the post-op histopathology was not collected. 2 months after the surgery, in October 2022, patient has recurrence of abdomen pain and abdomen distension with new onset symptoms of headache and blurring of vision. So for the following complaints, patient went to the nearby hospital. So he was diagnosed to have hypertensive encephalopathy, acute kidney injury, and obstructive uropathy. Imaging done at that time, it showed a bowel wall thickening in the operated site in the right iliac fossa, suggesting a local recurrence with a retroperitoneal nodal mass. And also around the kidneys, there was perinephric fluid collection with obstructive uropathy. So the post-op histopathology of the surgical specimen was checked again. So it showed intermediate sized atypical lymphoid cells infiltrating into the full thickness of the bowel wall. With the suspicion of lymphoma, the hospital did not have the resources to manage the patient. So he was referred to our institute 6 months from the time he started developing symptoms in November 2022. So at presentation, the problems we faced were the oncological emergency the child had. He was an anuric acute kidney injury. So he needed to be started in renal replacement therapy. So we managed the patient with the renal replacement therapy with an anti-tumor lysis syndrome measures, and his renal failure part settled. Then simultaneously, his obstructive uropathy component was also managed with the bilateral percutaneous nephrostomy, and the urinoma collection around the kidneys was drained through aspiration and subsequently through pigtail drainage. For the primary disease, the biopsy slides were reviewed at our institute, which was suggestive of Burkitt's lymphoma. Staging workup wise, bone marrow showed 27% atypical cells, and CSF cytology was negative. So he was diagnosed as Burkitt's lymphoma, stage 4, group C. So the child was managed with initially pre-phase chemotherapy, which included rituximab, cyclophosphamide, vincristine, and prednisolone, and short pulses of chemotherapy with the addition of doxorubicin in the second cycle. And the subsequent cycles, after we had added methotrexate, after the urinoma collection was drained. And so this case, as we can see, shows the problems which are unique to low and middle income countries, with delayed diagnosis leading to an advanced disease at presentation and multiple challenging complications this child had faced. And this also emphasizes the need to increase the awareness among the primary care physicians and an early referral to a tertiary care center. Thank you.
Thank you. Thank you, Dr. Mangai Suseela, for getting us up and running. I now have the pleasure of introducing Dr. Chantal Bouda to you. Dr. Chantal Bouda is a pediatrician practicing pediatric oncology since 2008 in Burkina Faso. Head of the pediatric oncology department at Yalgado Rodrigo University Hospital, Burkina Faso. Member of SOBUPED, member of Burkitt's Lymphoma Committee in GFAOP, and member of SIOP.
Hello, everyone. Est-ce qu'on m'entend? Share. Je vais partager. Je share.
Yes, we can see it.
Okay. Hello, everyone.
Can you make it full screen?
Yeah.
The next one with the cup. Yes, this one. Thank you. Yes, we see it.
It's a great pleasure for me to share with you this important session about Burkitt lymphoma. First, we are going to give some characteristics about Burkitt lymphoma remembers on lymphatic system, epidemiology of Burkitt lymphoma. Burkitt lymphoma is non-Hodgkin lymphoma, mature B cells lymphoma. It is a proliferation of mammalian lymphoid cells developed predominantly in extranodal tissues. It's very aggressive and very fast growing with a very short duplication time. It involves early central nervous system and bone marrow. The lymphatic system is a network that defends the body against disease. It has three components. The first one is lymph nodes. The second component is lymphoid tissues and organs that include thymus and bone marrow that are the primary organs, adenoids and tonsil that constitute Valdes wings, spleen, appendix, and pair patches that constitute lymphoid tissues associated to the intestine. The third component is lymphatic vessels. Epidemiologically, Burkitt lymphoma is found all over the world, but it's more common in the Burkitt belt in sub-Saharan Africa, where it represents more than 50% of childhood cancer. When to suspect Burkitt lymphoma? Clinical manifestation of Burkitt lymphoma predominate on two sides. The first one is abdomen. That is most affected in almost all publications. Head and neck localization is the second site, and it's more found in sub-Saharan Africa. Then come other sites with the risk of early invasion of central nervous system and bone marrow. The age of occurrence of Burkitt lymphoma is around 7 years old. It's rare before 2 years old, and clinical presentation is usually an increase in the volume of abdomen, sometimes preceded by abdomen pain, mass perception by patient or parents, and clinical evidence of mass and or ascites. The second site of localization for Burkitt lymphoma is head and neck tumor. It can manifest as dental pain, followed by gingival hypertrophy and mass in the mouth, disorganization and tooth loss, and finally, maxillary swelling. The other sites of head and neck tumors are tonsillar enlargement revealed by examination, or an orbital involvement, and sometimes we can have cervical lymphadenopathy. Some patients consult after those two main sites of Burkitt lymphoma. Some patients consult at the stage of neurological manifestation, which includes central nervous involvement as cranial nerve sulcis, decreased visual acuity, paraplegia, other neurological signs. Bone marrow involvement is announced by bone pain or another signs of bone marrow failures, such as anemia or hemorrhagical syndrome. Burkitt lymphoma can be revealed by an emergency, like acute antisusception announced by pain and occlusive syndrome. Compressive complication has respiratory distress by voluminous head and neck or mediastinal tumor, pleural effusion or ascites, digestive compression by large pelvic tumor or ascites, spinal cord compression. And then sometimes tumor lysis syndrome can reveal Burkitt lymphoma by oligoanuria. Clinical, outside of emergency, other more rare sites of tumor may reveal Burkitt lymphoma. Testicles, peripheral lymph nodes, thyroid, breast, members, thoracic. The list is not exhaustive, and all of these tumor sites may or not be associated. In paraclinical level, 2 examinations can support the suspicion of Burkitt lymphoma. Ultrasound is a very good examination to guide the diagnosis and extension of lymphoma. It describes the lesions and intestinal thickening, their size, their relationship with the organ, spleen, liver, kidney, ovaries, other sites, adjacent lymph nodes or ascites, and in all those differential diagnosis has nephroblastoma. X-ray describes bone lysis, mediastinal involvement, and pleural infusion. In conclusion, Burkitt lymphoma can be suspected in a child of school age presenting recently, a few weeks to a few months, an abdominal mass preceded by pain or revealed sometimes by acute antisusception, with or a maxillofacial mass with a dental pain, tonsillar or orbital starting point, with or another localization that can be early in the central nervous system or bone marrow, or compressive complication or tumor lysis syndrome. This constitutes a diagnostic and therapeutic emergency that requires a reference in pediatric oncology for management. For the end, I would like to thank SIOP for the honor that was made to me by this invitation. All of those who are following us at the moment, the patients of the department, caregivers of the service, I thank GFVP and Dr. Catherine Pat for her valuable advice and constant support. Thanks all.
Well, thank you, Dr. Bouda. It's always a great pleasure to hear from a true expert, and you certainly qualify as that because I think you've seen more Burkitt lymphoma than anybody in Western Europe. I spent a month in Tanzania, and I have to say I saw more Burkitts there than I would see in a whole year in Dublin. So thanks very much for that insight. I'd like to introduce Dr. Asim Belgaumi now. Dr. Belgaumi is at the Aga Khan University Hospital and is a professor of pediatric hematology and oncology there, and also the Dean of Clinical Affairs at the Medical College. He's the president of the Pakistan Society of Pediatric Oncology and a past president of a wider group in the Eastern Mediterranean. He's also highly involved in SIOP, and his interests are leukemia and lymphoma. So I look forward to hear your presentation, and thanks for joining us.
Thank you, Dr. Murti. So I'm going to start sharing my slides. All right. So I really want to thank the first two speakers, because they've made my life easier, because a lot of what they've said really helps me go through the rest of the management quite quickly. So the first thing, and this is really the last point that Dr. Chantal Bouda made, is that Burkitt lymphoma is an emergency. There's an urgent timeline that we need to follow. This is the fastest growing tumor in humans. And the treatment and outcome is dependent on the stage. And as time goes on and disease spreads, the stage increases, and there is a requirement for more intensive therapy. And so the earlier, the faster the patient can be referred for appropriate diagnosis and management, the better the outcome is for the patients. All right, so what do we want to do right up front? What are the initial things that need to be done? Well, a CBC with a differential, and I think that is really important because and we'll talk a little bit more about that as we go into how to come up with an initial diagnosis. And as Dr. Chantal said, that not infrequently the bone marrow is involved, and if the bone marrow is involved, very likely your CBC is going to be abnormal, and any abnormalities in the CBC should point towards a possible bone marrow involvement. BUN and creatinine, just renal function studies. Again, we've seen that there are multiple reasons for renal dysfunction, and we'll talk a little bit about that, both in Dr. Mangai's case that presented, as well as what Dr. Chantal talked about. In both of them, there was a significant mention of renal dysfunction. Electrolytes, particularly potassium, and again, related to tumor lysis, same thing with calcium, phosphorus, and uric acid that is available. And of course, lactate dehydrogenase, if that is available to the practitioner at your institutions. This is just an indication of how widespread or how rapidly growing the tumor might be. Again, we've talked about chest X-ray and ultrasound abdomen. You want to see whether there's mediastinal mass. This is an unusual involvement of in Burkitt lymphoma, as well as lung parenchyma, which is a rare late disease involvement. However, it's important to at least get a plain film of the chest because that gives an idea of how the patient is doing. Also, with the chest X-ray, you will be able to assess the trachea. Not so much in Burkitt lymphoma, but we've seen this is that because of head and neck tumors, you may have tracheal deviation, and that will impact on the possibility of respiratory dysfunction. And as you move forward towards your management, whether you can or cannot provide any sedation to that patient for procedures that might be required. Ultrasound abdomen, is there a mass? Has the mass resulted in any organ obstruction, whether this is intestinal or urinary? Is there any abnormal echogenicity of the renal parenchyma? Because that's another reason for renal dysfunction, not just from tumor lysis, but also from infiltration of the renal parenchyma by the tumor itself. How do we come up with a diagnosis? Well, really, you've got to choose the most accessible source of tissue. If there are abnormal cells in the peripheral blood becomes a really good source for that. You don't need to do any sedation or any procedure or any invasive procedures. A blood sample is able to tell you whether this is a Burkitt leukemia or not. If not, you go to superficial lymph nodes. If there are abnormalities in the CBC without any abnormal cells being seen, so platelets are low or anemia is there, then you've got the bone marrow, which becomes an accessible tissue. Again, where you can't do excisional biopsies, excisional tissue sampling, you can do core biopsies of masses. Now, we don't want FNAs because you read that then has the potential for incorrect diagnoses or missing the diagnosis, and a needle biopsy where you get a core would be useful in here. Again, you want to go for biopsies that provide tissue. This could be either incisional if there is tumors, or excisional if there's a smaller lymph node that is available for easy access. Again, I want to caution that this is not a surgically treated disease, and so heroic surgeries that remove large masses should not be taken up here. You should try and ensure that you have adequate tissue before you start any treatment, if you are going to start any treatment, for example, steroids, because this tumor is very, very steroid responsive. And sometimes if treatment has been started without appropriate diagnostic material being collected, you may end up with no tissue diagnosis because the tumor has essentially melted away with the steroids. However, if there is a life-threatening condition and you are unable to retrieve a diagnostic sample, then we don't delay starting treatment, and the treatment should be started because if your patient succumbs to the life-threatening condition, then there's no patient to treat anyway. So you've really got to be astute about how you take this forward. So both in the case that was seen and as mentioned by Dr. Chantal as well, a lot of patients will present with intestinal symptoms, and intestinal obstruction becomes something that one would need to deal with fairly urgently. Intussusception, because these tumors can occur in the ileocecal region, and as was in the case as well that Dr. Mangai presented, the patients can present with intussusception and obstruction due to that. If the tumor is small enough, and oftentimes patients who are presented with intussusception have fairly small tumors, you can actually do a radiological reduction if that is a facility that's available within your institution, or they can be surgical reduction of that intussusceptum and resection of that tumor. Oftentimes, when a limited resection is done, the surgeon is able to do a end-to-end anastomosis, and the patient then can be referred forward. Certainly bowel obstruction, otherwise they can be complete or partial obstruction. You've got to look for ruptured bowel in there. The most important thing here that one needs to consider is if the patient can be managed using conservative means. If possible, surgery should be limited to only retrieving diagnostic material. And really, again, no heroic surgeries, no large bowel resections, avoidance of creating stomas or colostomies, etc., as much as possible, because that will hamper further treatment for these patients. Resection should aim to relieve the obstruction. So do not attempt to remove all tumor. Try and do a primary anastomosis, and the removal of small intestinal tumors will result in a downstaging. So if there's a small tumor, for example, one that one might see in an intussusception, your surgeon can go ahead and do a limited resection, and that would result in a smaller tumor load for the patient and easier treatment. Urinary tract obstruction, the patient that was presented earlier, actually the second time when that patient came back, was with urinary tract obstruction. This can be ureteric obstruction because of a mass. It can be unilateral or bilateral, again, depending on where that tumor is actually causing the obstruction. These can be treated with ureteric stenting or urinary diversion. Pigtail stent tubes can be placed in there just to allow that the urinary flow for that patient proximal to the obstruction. Renal infiltration can either be because of the tumor infiltration within there, and this really a lot of time will require lymphoma directed treatment. If this is pure renal obstruction, intrarenal obstruction, oftentimes these patients may require hemodialysis until the kidneys can actually be opened up. Tumor lysis, as was again seen in the case that was presented, can happen resulting in urate nephropathy, and I'll talk a little bit about that. And what's very important to note is that this can happen even before any treatment is given. Definitely the risk is much higher once treatment is given, but particularly in Burkitt's lymphoma, where these cells are rapidly multiplying and dying normally as well, you can have tumor lysis happening before any treatment is provided to them. So tumor lysis syndrome. So the tumor lysis syndrome is a result of cell death and release of intracellular chemicals. The most important intracellular electrolyte is potassium. And so these patients can and often will present with high potassium. There's release of uric acid as a consequence of purine degradation. And this crystallizes at low pH within the kidney. And this can result in renal, tubular, and glomerular obstruction because of crystalline deposition within there. This results in decreased urinary flow and allows for more precipitation. So really results in a cyclical damage to the kidney in there. Hyperphosphatemia, which leads to hypocalcemia. And actually hypocalcemia is more concerning than hyperphosphatemia, and that can result in muscle cramps, tetany, and seizures that these patients may have. So the aim for any patient with suspected Burkitt lymphoma is to diagnose and safely transfer to a treatment facility. And the reason for that is to avoid disease progression, as I talked about earlier. You've got to prevent or manage consequences of tumor lysis syndrome, treat acute life-threatening conditions, and then transfer safely. So what do? Hydration, making sure that the urinary flow is there. Usually we will use 3000 ml per meter square. Alkalinization that used to be practiced earlier is no longer considered essential as long as we have adequate hydration and urine flow. You treat the hyperkalemia, potassium binders such as K-exilate. It's very important that potassium not be added to routine IV fluids. We should accept lower levels of potassium. So if a patient comes in, has a potassium of 2.9 or 3, I'm very happy with that. And really significant hypokalemia should be treated with bolus doses of potassium rather than infusions that run all day long, and preferably oral boluses rather than IV boluses. Monitor cardiac rhythm, provide IV calcium, dextrose with insulin, albuterol nebulizers. These are all things that one can use to decrease the hyperkalemia. Reducing or preventing hyperuricemia. Again, this is just the purine pathway, metabolism pathway. Uric acid, which is the end product for mammals and humans, is really what causes the problem here. Allopurinol, which has been used for over half a century now, actually 60, 70 years actually, really results in a block of the enzyme xanthine oxidase, which prevents the formation of uric acid. More recently, rasburicase is used, which is an enzyme that is not found in mammals, but is found in birds and reptiles, and results in the conversion of uric acid to allantoin, which is very, very highly renal, water soluble, and therefore it reduces the uric acid. So talk to the oncologist at the referral center. And I think that is key. call them up, write to them quickly and get in touch with them. Make sure that they can guide you in what is the best way to transfer this patient. Ensure that your institution can handle the problem, handle problems that may occur with the treatment. So even if it is utilizing steroids, and if your institution does not have the ability to take care of renal dysfunction, such as a result of hyperuricemia that probably may occur with any kind of treatment, even with low-dose steroids, then you may be better off postponing that till the patient can actually be transferred there. We can use low-dose methylprednisolone, but it has to be very judicious dosing with very careful monitoring. Again, hemodialysis may need to be done, and surgery oftentimes may need to be done when there's intestinal obstruction, just to relieve that intestinal obstruction. So thank you, and I'll be happy to take questions, and the panel, of course, will be happy to take questions as we end this. Thank you very much.
Thank you, Dr. Asim Belgaumi, for the great presentation, and first of all, impressing how urgent it really is. I'd just like to say that I'm going to repeat this later on, but this session will be available as a video on YouTube. I'm not sure when it'll be uploaded, but it'll be uploaded fairly soon. So I'd now like to introduce Andishe Attarbaschi. Dr. Andishe Attarbaschi is an assistant professor in pediatrics and adolescent medicine, senior consultant in pediatric hematology and oncology. He has been contributing as study coordinator and principal investigator for several Austrian leukemia and lymphoma studies, specific area of interest in training and expertise in pediatric hematology and oncology, and has a vital role in SIOP Europe educational offerings. He's one of these people you meet who doesn't sleep, and he just spends every hour of every day helping children with cancer, and I salute you. Right, away you go.
Thanks, Neil, for these very kind words and invitation. And I think after having seen these 3 great talks, it's not so easy to add so many things to this topic. But if I'm allowed, I would like to mention 2 aspects. The first one is dealing specifically with the patients with abdominal tumors who not always, but often present with intussusception. And I think if we have a non-infant presenting with an intussusception in combination with an increased LDH or uric acid level, there are not so many alternative diagnoses possible than Burkitt's lymphoma. I think this is also very important to always take into account. This combination, I think there are no other diagnoses possible. And the other thing what I would like to mention is because all the speakers said that Burkitt's lymphoma is an emergency, which is definitely the case, is that we don't need the histopathology to make the diagnosis of Burkitt's lymphoma, because we have many patients presenting with malignant effusions like ascites and pleural effusions. You can just take the fluid, do a cytospin, look yourself into the microscope. I'm doing this every day, and diagnose Burkitt's lymphoma. And even if you don't have a malignant effusion, and you take a sample during the operation, before sending the sample to the pathologist, you can make tumor touch imprints on a slide, do the staining according to Pappenheim, look into the microscope, and then you see the classical Burkitt cells, and you can start the treatment according to your protocol. So it's not needed to wait for histopathology in many situations, because the Burkitt cells have a very characteristic morphology, which is not so difficult. Yeah, these are the 2 aspects I would like to add to these 3 great talks, and thanks for allowing me to be a member here in the panel list and take part of this session.
Thanks, Dr. Attarbaschi, for sharing your expert opinion with us. Next, I would like to introduce Dr. Monika Metzger. She's a pediatrician at Medicine Sans Frontières, having recently completed her first assignment in the Democratic Republic of Congo. Previously, she worked for over 20 years at St. Jude Children's Research Hospital, where she was a full member in the Department of Oncology and Global Pediatric Medicine. Her areas of expertise are lymphomas, particularly Hodgkin lymphomas. She mentors juniors faculty and helps develop lymphoma protocols in Latin America, India, and South Africa. Welcome, Dr. Metzger.
Thank you very much, Claudia, and thank you very much to all the panelists and the participants. I am overwhelmed by the number of participants to this seminar, so congratulations, Mohammed and Claudia, for organizing this. This is incredible. So I have just a couple of comments. I would like to thank Dr. Mangai, Dr. Chantal, and Dr. Asim for their presentations. What stood out for me on Dr. Mangai's presentation, case presentation, was really a health system failure. And we don't speak often enough about the health system failure. We put the burden on the parents. You know, why didn't the parents come back and check the histopathology? But in reality, was it really the patients or the parents' responsibility to do that when they don't understand? Maybe were not even explained what the consequences are, or maybe even what the disease was. So I think it is important to put more responsibility on the physicians and to provide a network that will prevent a patient to fall through the cracks. So I think we need to start focusing a little bit more on the whole network and not maybe just blame it on patient education. Dr. Chantal, thank you very much for the nice summary of diagnosis and presentation of Burkitt lymphoma, including the epidemiology and the clinical challenges, particularly in Africa. As Claudia said, I just spent 6 months in Africa, and I can tell you that yes, we did see some Burkitt lymphoma of the jaw. Unfortunately, there was nothing that we could offer, not even prednisone for these patients. So they couldn't be referred to a place where they could be treated. But one of the things that did call my attention is the acute abdomens and perforations that we see in Africa that maybe we don't see in other places, and these are secondary to typhoid fever. So not every acute abdomen is going to be a Burkitt lymphoma, and so that is something also to keep in mind. And of course, Dr. Asim, what a wonderful presentation on the management diagnosis of Burkitt lymphoma, as well as of its complications. So thank you so much for having me. It's really an honor to be part of this panel.
That's great, Monika. Thanks very much. And I have to echo my gratitude to everybody who's contributed to this. And I have to say the practice that I've heard about here absolutely mirrors our practice in Western Europe. I might speak more about that towards the end, at the very end of the webinar. But I need to introduce Dr. Murti Andriastuti, who is from the University in Indonesia. She's an active faculty member there and is also involved in the Indonesian Oncology Association. She's academically very, very active and has peer-reviewed or has co-authored and mentored many, many papers in peer-reviewed journals. So I look forward to hearing your thoughts. So thank you.
Thank you, Dr. Marque. And then thank you everybody for this opportunity for me to join this session. I want to make a point of view from the case from the Dr. Mangai. I think this sometimes happen also in my country, because I think that is very important, this awareness from how to get the early diagnosis to this is malignancy or benign. because this from history taking, we can differentiate between is this malignancy or is this benign from the tumor. So this is very important from the general doctor to know about this from the history taking, and also we can check from the physical examination and then from the initial laboratory examination. And then we can think first this is about malignancy, then we can refer them as soon as possible, because when we suspected this is malignancy, particularly lymphoma, this is like Dr. Belgaumi talk about this is the fastest growing from the one of the cancer fastest growing. So we have to refer this patient as soon as possible to get the treatment, to get the diagnosis that have to make sure this is the malignancy, that what kind of malignancy, because we have a lot of differential diagnosis from these lumps that the patient from the case presentation from Dr. Mangai. And then after surgery, the patient took the surgery. I think this is they have to look for the pathology after they did the surgery. I think this is also the miss in this time. So patient didn't come again, and then not control again to the hospital. So we don't know about what kind of from the tissue that already take out when the patient get the surgery for their lump. So we miss this time period around 3 months. So this is very, yes, the disease can spread anywhere, and then the prognostic maybe will go bad, because this is the delayed diagnosis. But I think in our medical side also make the delayed diagnosis and also the treatment, not only because of the patient, but also from our side. So this is very, very important to give education for the maybe general doctor or general pediatrician, from awareness to be how to early detection, early signs of the malignancy, and also how to refer the patient as soon as possible if we suspected this is malignancy, or we doubt about this is malignancy or benign. So we must think first this is malignancy, so we have to refer the patient as soon as possible. So after that, the doctor from the bigger hospital or for cancer center can make certain diagnosis, this is a malignancy or not. I think that's very important from the case that Dr. Mangai already presentation, that we can learn from that case. Thank you.
Thank you, Dr. Andriastuti, for your valuable insights. I think we are ready for the Q&A session. There are a lot of questions, very interesting questions in the Q&A box. Isabel Villaradi wants to know if we know why Burkitt lymphoma is more frequent in sub-Saharan Africa. Dr. Attarbaschi, do you want to answer that question, please?
I think I would leave this question perhaps to someone else, because this is not my field where I can answer this properly. I don't know whether Monika and or my other colleague can answer this question.
Yeah, well, I would suggest that it's the effect of EBV, which is very prevalent in Sahara or sub-Saharan Burkitt. We have EBV in Western Europe as well, but we don't see the same incidence of EBV-driven Burkitt lymphoma. So perhaps there's some predisposition to EBV-driven lymphoma in sub-Saharan Africa, and it's a combination, I'd say, of an inherited predisposition and the presence of the virus.
There is also a relation to the malaria belt. So it's also malaria plays there a role as well.
Thank you. Dr. Chantal, do you want to share some comments about that?
You're muted, Chantal.
You're still muted.
Please, what's the question?
Now we can hear you. If you want to share some with us some comments about why Burkitt lymphoma is more frequent in sub-Saharan Africa.
No, it's because of EBV and malaria, and so more cancer is not diagnosed. And it makes, comment on dit, qu'est-ce que je dis ça? It is because of more of the cancer is not diagnosed, and Burkitt lymphoma is the first one that can be diagnosed with cytology. Donc, I think that it's what Burkitt lymphoma is more dense in sub-Saharan Africa. Je vais dire
Can I just add to everyone, if you're adding questions and we don't get a chance, we might not get a chance to answer all your questions, please add your email to the question, and then we can get your questions answered after the session if necessary, because you see there's quite a few questions in the question and answer box already. So if you just add your email, we can get back to you afterwards if necessary.
There was a very interesting question about how to differentiate between tonsillar involvement by lymphoma versus chronic tonsillar hypertrophy by infection. Monika and Dr. Angus, do you want to make some comments about that?
Do you want to go ahead, Monika?
Sure, thank you. So unless there is a change in stage or risk stratification, it really doesn't matter, unless this is the only place where the lymphoma is harboring, and then you need again histologic confirmation. When I say histologic, and as Andishe also said before, you can just do a touch imprint that will show you if indeed there is Burkitt lymphoma. So it's not even a very complicated way of proving that there is involvement or not. Now, if the patient has other sites of involvement, whether the tonsils are also involved, really doesn't make any difference anymore. And so I wouldn't, if it is an asymmetric enlargement, then that speaks more towards, okay, that's probably lymphoma than if it is symmetric. You cannot go by the response to chemotherapy because even hypertrophic tonsils will respond to chemotherapy. So that will not help you, particularly to the steroids. So, but I see that Andishe has also a comment on this, so I'll let him talk.
No, I just remember a case at my ward myself, and it's specifically referring to what Monika said. If you have a unilocular tumor on one of the tonsils and no other manifestations, of course, you need to do something to get a diagnosis, but you don't need to do a tonsillectomy. We just did a tumor touch imprint, had the diagnosis, and we confirmed by FISH that it was symmetrically arranged, and we gave 2 blocks and the patient was cured. But this is a rare situation. And in the other cases, as Monika said, if you have other manifestations, you have the diagnosis, you don't need to confirm that the tonsils are involved or not.
Yeah, I agree entirely. And if you've got the diagnosis elsewhere, you don't need to worry about the tonsil that much. And it'll rarely move you, upstage you. It certainly won't move you from group B to group C unless you've got CNS or bone marrow disease. So I would just probably treat as if it is, and then cut back if it turns out not to be.
Okay, I've got a question for you, Andishe. So this is from Bang in Indonesia. My name is Bambang Sudarmanto, Indonesia. Can the peripheral blood smear used to monitoring and evaluation of MRD in Burkitt lymphoma?
I saw the question already in the chat, and I'm not sure whether I understood it completely. Usually Burkitt's lymphomas do not spread into the peripheral blood. Even if it's a Burkitt leukemia, you usually have no Burkitt's cells morphologically visible in the peripheral blood. So blood smears cannot be used to monitor disease. Of course, there are more specific methods like PCR-based methods by which we try to monitor by the gene fusion the disease in the peripheral blood and in the bone marrow. But currently, this is not used even in Western Europe, and I think also North America, to stratify patients, although there are a few papers have been published that minimal disseminated disease in the bone marrow and peripheral blood as measured by PCR-based methods or after the first 2 blocks can be prognostically important, but this has not been used in our international multi-center trials yet. But when you say smears, this would mean to me that you are talking about morphology, and morphology is not something that you can use to monitor disease response, even not in BLL, in peripheral blood. Of course, in BLL cases, you can use bone marrow, you must use bone marrow to assess the treatment response. I hope that I understood the question correctly. But perhaps Angus and Monika can add something to that.
Yeah, I certainly agree entirely. And I think T-cell lymphoblastic leukemia lymphoma is the only disease where what you see in the peripheral blood reflects the marrow, and you can get prognostic significance from peripheral blood MRDs. So certainly in Burkitt's, we've never used it and never have sought to use it, because I don't think peripheral blood MRD has any prognostic significance in Burkitt lymphoma. I wish
agree.
It did,
yeah,
but it doesn't. Sorry, Monika.
no, I don't have anything else to add. I agree.
Do you have any comment on that, Murti?
Yes, doctor. About the how to what the problem that sometimes we have to refer or access from the patient to go to the cancer center. But now we have the like insurance from government insurance. So all the patient covered by government insurance. And then sometimes we can also, the problem is about the early detection that from the general doctor or general pediatrician, because in our in rural area, sometimes it's very rare to find the case with the malignancy. So sometimes they try to give the treatment first, and then after that, it's not better. So after that, they will refer to the cancer center. But this is very, very difficult, how to educate the general doctor how to know about the early detection. And then that's why we always educate from the medical side, when you doubt about the disease malignancy or disease benign, and then we have to think first this is malignancy. So after you refer, and then we will find out about this disease, make sure this is malignancy or not. So no need to just to treat. They think this is not malignancy, but like the case that Dr. Mangai presentation, this is the delayed diagnosis, so maybe can impact the from the outcome from the patient. So now we have the insurance, government insurance, that all the treatment from malignancy patient can cover by the government. So this is very get the benefit for our patients.
There was a couple of questions about how we can improve the time to diagnosis. Dr. Belgaumi, do you have any comments on that, especially in a low and middle income situation?
Well, I think that is the critical thing in Burkitt lymphoma, is as you know, all of us have been saying that there is a certain urgency that's required within there. And really what many of the comments that have been answered and what has been said here is that the requirement for a strong suspicion or a diagnosis of Burkitt lymphoma is fairly small. A lot of what we can do can be based on a clinical presentation of the patient, and simple things as Dr. Attarbaschi has been saying, touch preps, using just smears, or looking at the cytospin of a acetic fluid, for example, can lead to a diagnosis for these patients. So really, what is required is the knowledge of the disease itself, and the knowledge of people who would potentially see these patients before they refer to the oncologist or the oncology center. And this could be surgeons. I mean, almost all intestinal obstructions will be referred to a surgeon initially. Any patient who comes in with cervical lymphadenopathy will be initially, in a lot of places, treated as tuberculosis before it goes on. We see that a lot with Hodgkin lymphoma more than non-Hodgkin lymphoma, but yes, that's what it is. So your index of suspicion really needs to be there. And so really, I think a lot of it can be circumvented with just education, as we are doing right now. And that knowledge will allow for these patients to be referred earlier on. There really isn't any huge requirement for infrastructure for treatment of Burkitt lymphoma.
Dr. Suseela, do you have any comments on that, how we can help improve the situation?
Dr. Suseela, can you hear us?
Yes, I can hear you.
So there was a question about how to improve the situation in low to middle income countries. I wonder if you have any comments on that. Thank you for your contribution,
Yes.
Dr. Belgaumi.
I would agree with what Asim sir told now, because our patient, he was seen by a primary surgeon, because in our setup, usually when somebody has an abdomen pain symptoms, it is usually seen by a surgeon. And like he presented with an intestinal obstruction like features and an emergency situation, so he operated on him. So, and the primary diagnosis, he underwent an imaging prior to the surgery, and it's noted a diffuse bowel thickening. So in our country, the first diagnosis will be an abdominal tuberculosis because it is an ileocecal region. An abdomen TB will be the first thing a surgeon will think of. And with an obstruction, he operated on the child. So, and there are multiple lapses in the subsequent events. The setup wise, it was operated by a primary surgeon. So they had sent for histopathology. And usually if it is a tertiary center equipped with histopathology, adequate follow-up, like if it is in our center, the same patient is operated, the Burkitt's leukemia, Burkitt's lymphoma is an alert for us. Immediately they'll call up from pathology department and they'll tell us it is Burkitt's, like that. So this is like, it was sent to a pathology lab for processing, and it would have been come after 2-3 weeks. By that time, the patient was asymptomatic. So the patients, we cannot blame. They thought they are cured of the problem and they were okay. So that system, we can probably inform all the pathology lab processings that if you find out a lymphoma, you have to inform the primary surgeon. And also we can increase the awareness among the primary surgeons. With an abdomen mass, we always have in back of the mind, lymphoma as a diagnosis, differential. That's what I wanted to tell. Thank you.
Thank you, Dr. Suseela. No, go ahead.
Yeah, one of the things that SIOP has tried to do is trying to help early diagnosis. So this is the whole theme of the CEDAR webinars. So we're not targeting pediatric oncologists, we're trying to inform other healthcare professionals. So diagnosis of cancer take place earlier. So this is exactly supporting what Dr. Belgaumi and what the other panelists have been saying. So SIOP, in conjunction with the IPA, are trying to help people, give them the knowledge to diagnose children quicker. So it's not a massive change, but it's all about education.
Dr. Attarbaschi, do you have some comments?
One very short comment, but I think Angus and Monika can also comment on this. I think the care of children with cancer in the Western countries has definitely improved by our teaching of the pediatric surgeons. So if patients present to them at the beginning of their disease, we have trained them that they should involve us from the beginning onwards, so that we are involved in the planning of the operation, and we usually send one of our pediatric oncologists to the operation room to be there and to see what the surgeon is doing and to decide what to do with the material, to send their CEDARs to this lab and the samples to the pathologist. So training of the pediatric surgeon, if this is in Africa the case, what I'm understanding now is that many patients present to the surgeons primarily, is that you train and teach the surgeons, that they involve you as the pediatric oncologist from the beginning onwards. Monika, you would like to add something?
Yes, no, I totally agree with you, Andishe, and I think we need to start to think about us as colleagues all, and that we are teams. So we don't work in silos, we work in teams. And communication, everything turns around communication always, right? So I think it is to start having more open discussions and a culture of communication within your own hospitals, and letting everybody know that all the patients are shared, because at any given time, my patient could become your patient and vice versa.
You are mute, Neil.
Sorry, there are a few questions that people have asked that I don't think we're going to have a chance to answer. If people leave their email address, then we will get back to you afterwards. Right. So I think that's the end of the question and answer session. Thank you for your contribution, everyone. I'll just share my screen. Right, I'm trying to click the right button. So there's the CME credit for everyone that attended this one. If there's any further questions about this seminar, then please email Dr. Sagir Khan. He's been instrumental in running these CEDAR webinars. They wouldn't have happened without his great work. There's video, all the previous CEDAR webinars are available on the SIOP YouTube channel. This one will be available on there soon, and they're available in English, and they have the Spanish subtitles. The next seminar is on Friday, the 10th of March, and that's the diagnosis and referral of Wilms tumor. And it takes the same format as this one, with world-leading experts doing presentations, and then there'll be a question and answer session, and this is on Wilms tumor. And together with the for ICCD 2023, the IPA and SIOP have done a series of videos about childhood cancer, and these are being promoted through social media on Facebook, Twitter, Instagram, LinkedIn, and TikTok. The first video has been produced by SIOP President Guillermo Chantada, and I think we're just going to see it now. These are just short videos. There's only one that's been published so far, but there's going to be a lot more coming soon. So I think the video is coming shortly.
Childhood cancer is curable. We have great possibilities of survival. The results in high-income countries show that around 80 to 85% of the children with cancer can be cured. However, there are very big differences around the world. In many countries, because of late diagnosis, because of cultural issues that make that the families will not accept the treatment that we propose, sometimes because of the health system is not adequate enough to treat the children with cancer. Unfortunately, in many countries in the world, despite childhood cancer is curable, children are not being cured. So that's why there is a big effort right now, a big global effort around the world with the WHO to achieve at least 60% survival in the 6 index cancers that are more curable. We are aiming to cure 60% of these children. However, in high-income countries, the cure rate for these children is about 90%. So yes, childhood cancer is curable, but we should cure childhood cancer around the world right now.
You are mute, Neil.
Sorry, I think that's over to Angus now to finish up.
Yes, yeah. Just really to conclude, I have to say I've been blown away by the quality of the presentations and the discussion. It absolutely reflects what we do in Dublin with close to unlimited resources. I think the principles of good clinical medicine are the same everywhere. So well done to the panelists and the moderators and the presenters. I'm glad this is going to be on YouTube, and the next Burkitt patient we have in Dublin, I will send my team off to look at YouTube and to review this this presentation as a very good grounding in what to do when the patient hits the tertiary care centre. So thank you, everybody. I've been very, very impressed, and special thanks to Claudia for her moderatorship and her impeccable timekeeping.
Thank you, Dr. Angus, and thank you everyone for being here with us today and sharing your knowledge, and all the participants for sharing their time with us. We want to improve our knowledge and to know more about this disease and improve the outcomes of our patients. See you in the next webinar.
Okay, great.
Thank you.
Thanks, everybody.
Thanks all.
Thank you, everyone. Thank you.